So this class will be on the vasculitis, which is one of the important topics in the rheumatology. So in the next few minutes, I would like to talk on overview of the vasculitis, some of the clinical patterns, your diagnostic aids, what are all the treatment paradigms, and some cases and the questions. See, this is a very big disease, vasculitis, characterized by the inflammation of the vessels, mostly the arteries. So there will be the vascular inflammation, and also there will be the necrosis of the blood vessels, and these blood vessels will become blocked, and there will be the distal ischemia to the tissues, and finally those tissues will get necrosed, and finally the organ dysfunction will occur. So this vasculitis is a multi-system disease, and most of the organs will be involved here because of the occlusion and the ischemia, and there are some immunological mechanisms will be there. So your B cells and the T cells, immune complexes formation. So these are all the immunological abnormalities will occur in the vessels, leading to the panvasculitis. So all the three layers of the vessel wall will be involved, and this all will lead to the multi-system disease with some of the constitutional symptoms like fever, malaise, easy fatigability, weight loss, arthralgia, and some inflammatory laboratory indices like elevated ESR, elevated CRP, and finally the biopsy is the gold standard in these diagnosis of the vasculitis. So with this introduction, we will move on to the topic proper. What you mean by the vasculitis? See, it could be a primary vasculitis or the secondary vasculitis. In primary, the exact cause is not known, maybe the genetical and environmental factors, and it's the principal feature is the primary vasculitis. Whereas the secondary, you have some cause like diabetes or RA or the lupus, etc. So these in secondary vasculitis, if you identify that secondary cause and if you treat that secondary cause, and obviously this vasculitis picture will be aborted. Otherwise, most of the times, no, this vasculitis is a primary vasculitis, and where the management will be very, very difficult unless you diagnose the vasculitis in an early time, and unless you introduce the immunosuppressive drugs like high doses of the steroids or immunosuppressive drugs like azathioprine, cyclophosphamide, mycophenolate mofetil, or some biologicals like rituximab, etanercept, etc. So the life of the vasculitis, people will die much early because of the vascular complications like aneurysm formation or premature atherosclerosis or ischemic heart diseases or CVA or renal artery stenosis or acute kidney injury or chronic kidney disease, etc. There is no universally acceptable classification in vasculitis, and vasculitis can be divided, depends on the vessel size, maybe the large vessel vasculitis or the medium vessel vasculitis or a small vessel vasculitis. And there are some histopathological characteristics are there, like your P-ANCA positivity, C-ANCA positivity, etc. And there is a dominant organ involvement. In some vasculitis, the lung is very much involved, whereas the other vasculitis, the lung is just spared, the kidney is involved, glomerulonephritis is a more common. In some vasculitis, there will be the RPGN, rapidly progressive glomerulosclerosis, nephritis, so etc. And there, and some cases, there the overlap vasculitis are there. So they looks like a small vessel vasculitis, but they present like a medium vessel vasculitis. And if you see the case properly, and that vasculitis is having both the small and also the medium vessel vasculitis. So some overlaps will be there, but definitely you should understand the many vasculitis pictures in a better way. And large vessel vasculitis, usually the two diseases you can remember by GT. So G stands for the giant cell arteritis, also called as the temporal arteritis, and the T is the Takayasu arteritis, a name given by the Japanese scientist who first identified this disease, that is a Takayasu arteritis. These two are the large vessel vasculitis diseases. And the medium vessel, you have the PAN, that is the polyarteritis nodosa, the Kawasaki disease. So polyarteritis nodosa is more common in the middle-aged individuals, whereas the Kawasaki disease is common in the children less than the 5 years of the age group, commonly presents with a cardiac problem. So that is the Kawasaki disease. And among the small vessel diseases, so there are the many diseases in the small vessel vasculitis, like Wegener's granulomatosis, So where the C anca is a positive here, that is also called as a vacanus or vaganus, because C anca is very, very important in the Wegener's granulomatosis diagnosis. And we have the microscopic polyangiitis, Henoch-Schönlein purpura, cryoglobulinic hypersensitivity, vasculitis, eosinophilic vasculitis, so etc. These are all the small vessel vasculitis. See, the first time, if you see the upper one, that is the Takayasu arteritis and giant cell arteritis, the mostly it involves the large vessels. In the medium vessels, the polyarteritis nodosa and the Kawasaki disease. And the small vessels, you will have the Wegener's granulomatosis with the C anca positivity. So you can also remember as the vacanus, microscopic polyangiitis and Churg-Strauss syndrome. And the cryoglobulinemia or cutaneous leukoclastic vasculitis or HSP, where arterial or the capillary venules will also be involved here. When to suspect a vasculitis? So it is an unexplained ischemia, presents in the form of the claudication, a limb ischemia, angina, transient ischemic attacks, stroke, young strokes, or mesenteric ischemia present with a chronic abdominal pain, cutaneous ischemia, so there will be the purpura, palpable purpuras. So these are all the cases where you should suspect the vasculitis. So a palpable purpura, think of the vasculitis. A mesenteric ischemia, so again the chronic abdominal pain, mesenteric, acute abdomen, acute and chronic, etc. So just again think of the vasculitis. And the young strokes, so it could be a vasculitis, especially in female individuals or in the males also. TIA, angina, again a vasculitis could be one possibility. And claudication and the limb ischemia, mostly it is a vasculitis, maybe aortic arch aortitis or aortic arch syndromes, etc. So multi-organ dysfunction is a very common in the vasculitis population, provided if you don't give the immunosuppressive drugs or high doses of the steroids at the right time. So definitely these people will become very ill, and also other suggestive features like heart failure features or CKD features or GERD features or chronic ischemia of the intestines or analgesic nephropathy or IgA nephropathy. So these are all the very, very important complications one can see in an uncontrolled vasculitis cases. What are the other suggestive features? So when a fellow presents with a glomerulonephritis, so why not it is a vasculitis? So only the glomerulus, or there is involvement of the lung also. So there is a pleuro and renal involvement, or sometimes involvement of the pericardium, pericarditis, etc. So the palpable purpura is always one DD for your vasculitis, and peripheral neuropathy is also very common in the medium vessel vasculitis and the small vessel vasculitis, and established autoimmune diseases like your ANA positivity, double standard DNA positivity, or low positivity, RA positivity, etc. So where there is an established SLE or an established systemic sclerosis or an established mixed connective tissue disorders or in the rheumatoid arthritis also, so you will have a vasculitis picture. So these are the different situations where a physician should suspect vasculitis in that particular individual. Must exclude an alternative diagnosis like in a sepsis. So what could be the reason for the sepsis? Drug toxicity, malignancies, and coagulopathies. What is the general approach to your diagnosis? So how to approach? Attempt to exclude the other processes. So mostly a secondary causes has to be ruled out. Consider the age. Suppose if the age is less than the 5 years, if you are suspecting in a vasculitis, the most probably it's a Kawasaki disease. Suppose if the age is the 70 years or the 75 years and throbbing headache or pain and palpation of your the temporal artery and the ESR is more than the 100, so then your diagnosis is the temporal arteritis or the giant cell arteritis. So the age is very, very important to identify certain vasculitis. Among the gender also. See, most of these vasculitis are more common in the males, but some vasculitis are more common even in the females also. So the gender also will help you a lot, and ethnicity of the patient. So most of the people, these vasculitis are very common in the Japan. They are very common in the Europe. They are also common in the Asian countries. Determine which organ systems are involved. So whether the lung is involved or the lung or the kidney is involved or the gut is involved, etc. And sometimes eye will be involved. So sudden loss of the vision. maybe the blocking of your terminal ophthalmic artery, a terminal branch of your external carotid artery. So again, it could be a feature of the giant cell arteritis. Okay, so estimate the size of the vessels are involved. That is also very important. Suppose if you plan for a biopsy, if you are suspecting the vasculitis, so at least 2 centimeters length of the vessel has to be taken for your biopsy, because there will be the skip lesions. So if you take only half centimeter or 1 centimeter vessel, so if that part is the normal, you are excluding the diagnosis. But if you take a large segment, so even though the patient is having a skip lesions, so that those can be identified or identified by our good pathologists, and then definitely there will be the fibrinoid necrosis or some necrosis or inflammation, etc., so that you can diagnose the vasculitis. So this is the demographic associations. So child, male and female equal incidence, that is an HSP, and male more than the females, Kawasaki disease. So Kawasaki disease is more common in the male children when compared to the female children. Young adult of your age group, see the male is to female, Behçet's disease. So aptus ulcers, painful oral ulcers, some genital ulcers, okay, or some the purpura or the arthralgia. So these are very common in the Behçet's disease. In the females more than the males, especially the Asians, especially the West Bengal, Orissa, and some part of the Andhra, you can have a Takayasu arteritis. So almost considered as a pulseless disease. So mostly aortic arch involvement will be seen in these diseases. Okay, so that is the age. So according to the age, in the children, HSP equal, Kawasaki disease more in the males. In young adults, equal in Behçet's disease. Females are more prominent in the group in Takayasu arteritis. In the middle age, Vasculitis, Granulomatosis, Polyarteritis, maybe microscopic polyarteritis, or Churg-Strauss syndrome. So these are more common in the males when compared to the females in the middle age group. In the elderly, as I told you, that giant cell arteritis or temporal arteritis, so more in the females rather than the males, more than the 60 years age group or 65 to 70 years age group. So this is very common in the giant cell arteritis. So taking an history is an art in vasculitis. So you have to take a very proper investigation, proper history. So some people, they will present like a jaw claudication. Some people, they will present with a tongue claudication. Some people will present as upper limb claudication, or limb ischemia, or angina pectoris, or throbbing headaches, okay, or hematuria, or some casts in the urine, proteinuria. So these are all the different visual abnormalities like uveitis, iridocyclitis, or retinal artery occlusions, ophthalmic artery occlusions. So these things, if you take an history in a proper way, in a rheumatology, I think history plays a very, very major role. 85% cases can be diagnosed with history alone, and your investigations may help you for about 10 to 12% or 15%. So that is the beauty of the rheumatology. So take a good history, and you identify these diseases very correctly, provided if you have a good background knowledge. So clues to the diagnosis. Already I give you one clue about the age. So young age group, or middle age group, or elderly, or the children. Now you see the palpable purpura. So palpable purpura, the most likely affected vessel is the post-capillary venules. It's a small vessel disease, not the medium vessel or the large vessel disease. Any type of the vasculitis except the giant cell arteritis and Takayasu arteritis. So you will have a palpable purpura here. Skin ulcers. Arterioles to the small arteries, a polyarteritis, Churg-Strauss vasculitis, Vasculitis granulomatosis, hypersensitivity vasculitis. You will have a skin ulcers because of the small vessel vasculitis and the medium vessel vasculitis. Gangrene in the extremity, a small to the medium sized arteries. So polyarteritis, Churg-Strauss vasculitis, Vasculitis granulomatosis. You will have a gangrene in an extremity, sometimes not to amputation, maybe because of the sudden blockage of the blood supply to the distal parts. So there will be the autodigestion of the toes will be there, or the fingers will be seen here. Abdominal pain or the mesentery ischemia. So the small to the medium sized arteries. Here the HSP, polyarteritis, and Churg-Strauss vasculitis will have the abdominal pain and mesenteric ischemias. Gastrointestinal bleeding. Capillaries to the medium sized arteries. Here the SSP, polyarteritis and Churg-Strauss vasculitis, you will have a gastrointestinal bleeding. So while taking a vasculitis picture, you should take a dermatological manifestations, gastrointestinal manifestations, cardiac manifestations, and then the pulmonary manifestations and the renal manifestations. Some may be the neurological manifestations. So it's a truly a multi-system disease. So the glomerulonephritis by the capillaries that applies to the kidneys. So there may be the microscopic polyangiitis, vaginous, cryoglobulinemia, Churg-Strauss vasculitis, or HSP. Ischemic renal failure, a small to the medium-sized arteries. Here again the same, the polyarteritis, Takayasu, etc. Pulmonary hemorrhage. So the capillaries less commonly small to medium-sized arteries, microscopic polyangiitis, and vaginous granulomatosis. So in vaginous granulomatosis, you have a pulmonary hemorrhage. So vaginous granulomatosis, you can have the both upper respiratory tract involvement and also the lower respiratory tract involvement. So upper respiratory tract involvement in the form of sinusitis, saddle nose deformity, okay, and maybe the septal perforation. So these are very common. Whereas the lower respiratory tract involvement, you will have the nodules, you have the cavitary lesions, and you will have a pulmonary hemorrhages, hemoptysis, etc. Pulmonary infiltrates and the cavities, a small to the medium-sized arteries, you have Churg-Strauss vasculitis and microscopic polyangiitis. Peripheral neuropathy. So again, because of the small arteries involvement, here the most commonly associated systemic vasculitis cases are polyarteritis, Churg-Strauss vasculitis, vaginous granulomatosis, and cryoglobulinemia. Stroke, young stroke, maybe because of the small and the medium sized or the large arteries involved here, giant cell arteritis, or lupus associated vasculitis. So what about the lab? How the lab will help you in diagnosing these vasculitis cases? So determine the organ involvement and accordingly you can advise. Suppose if you are thinking that is a pulmonary hemorrhage or maybe the pulmonary nodules, etc. So you can order for your CT chest. You are thinking about the renal and definitely you need a renal biopsy or ultrasound of the kidneys or MRI of the kidneys, etc. So exclude the other diseases, the routine labs like complete blood picture. And most of these diseases and vasculitis, you will have a thrombocytosis rather than the thrombocytopenia. So thrombocytosis is very common in the vasculitis because of the accumulation of these platelets, and there will be the fibrin formation and then the blocking of the vessels, etc. ESR is always elevated in the vasculitis, sometimes more than the 80, 90, 100, 120, 140. So very high ESR is very common here. And CRP. So high CRP is also there. Normal CRP is up to the 6, whereas some people may have the 60, 80, 100, 120, 220 also CRP. And this ESR and CRP will help you in the initial days for the diagnosis, and later for a prognosis also they will help you. In continuation of your steroid therapy or in initiation of your immunosuppressive therapy, that also will help these two things. Suppose if your diagnosis is giant cell arteritis and that fellow is having the ESR of more than 110 and then the CRP is about 200 and you initiated on high intensity steroids, maybe prednisolone 1 milligram per kg body weight. So that means about 60 milligrams of the prednisolone or 80 milligrams of prednisolone, and I have used it for about 8 weeks or 9 weeks or 12 weeks till you get the good response, and you want to taper the dose. So how to taper the dose? So what is the indication to taper the dose is your ESR and CRP. So on the day 1, if the ESR is about 110 and the CRP is about 200, and after 6 weeks or after 8 weeks or the 12 weeks of your high intensity steroid therapy, suppose if the ESR and the CRP are the same, so that is not the time to reduce the doses of the steroids. You have to continue for some more period, or you have to add the other immunosuppressive drugs like azathioprine or cyclophosphamide or methotrexate or mycophenolate mofetil, etc. So this ESR and CRP will help you in 2 ways. One, initial times to know the severity of the vasculitis, and after latter word to de-intensify your steroid therapy or to add immunosuppressive therapy along with the steroid therapy. Am I clear? So LFT is also very important to know whether there is any fatty liver or whether there is any associated hepatic involvement in these diseases. Infections, yes, one of the DD is the sepsis. So definitely you need the cultures, not only the culture of the blood and the urine. So other cultures also, maybe the culture of the pleural fluid, culture of the pericardial fluid, culture of the serous fluid. So these are also very important. And viral serologies. So HPV. So this is very, very important. 30% is associated with the Vasculitis granulomatosis. So these are very important. HCV association is very there. And HIV association is there. Cytomegalovirus, influenza viruses. So they are also very commonly associated with your vasculitis. And then management differs. If it is HPV associated with vasculitis, you have to use some drugs. And if HBS is negative, you have to use the other drugs. Autoimmune serologies, so these are all very common. ANA is positive in most of the immunological diseases. If the double stranded DNA is also positive, then more of specificity for your SLE. And rheumatoid factor positivity or anti-CCP positivity, more of the rheumatoid arthritis. And even sometimes in vasculitis, so maybe ANA may be falsely positive, rheumatoid factor may be falsely positive. So presence of the rheumatoid factor itself is not an indication to diagnose it as a rheumatoid arthritis. So the same ANCAs, I told you, the P ANCA, the C ANCA, in Wegener's you will have the C ANCA positivity. Double-stranded DNA is more in the lopus, and the C3 and C4 are the complement levels. So there will be the hypocomplementemia is also there in most of the vasculitis diseases. And miscellaneous tests like the creatine kinase, anti-glomerular basement membrane antibodies, and cryoglobulins, etc. This is the C ANCA and the P ANCA. So antibodies directed against the neutrophil granule constituents. So antibodies against your neutrophil constituents. C is the cytoplasm. Hence C stands for cytoplasm. Main target antigen here is the proteinase 3. Highly specific for the Wegener's. So C ANCA is highly positive for your Wegener's granulomatosis. Here C stands for the cytoplasm. So the main target antigen here is the proteinase 3. P ANCA is the perinuclear. P stands for perinuclear. Here the main target antigen is the myeloperoxidase. Proteinase 3 is for the C ANCA, whereas the myeloperoxidase is for the P ANCA. Here it is mostly associated with MPA and Churg-Strauss syndromes. Okay. Microscopic polyangiitis is the MPA. Microscopic polyangiitis and Churg-Strauss syndrome. You will have a P ANCA positivity. C ANCA for your Wegener's granulomatosis. So how the small vessel vasculitis can be divided? So small vessel vasculitis can be divided into ANCA positivity and ANCA negativity. So ANCA positivity again, ANCA C positivity, C ANCA positivity and P ANCA positivity. So C ANCA positivity Wegener's, P ANCA positivity Churg-Strauss and microscopic polyangiitis. What are the ANCA negative small vessel vasculitis? Your cryoglobulinemia. Okay. So your some lymphomas or Bisset syndromes. So these are ANCA negative small vessel vasculitis. I told you the biopsy is the gold standard. So the blind biopsy generally low yield, less than the 20%. So go where the money is. So that is a wise biopsy. The long-term, long segment biopsy is very much needed here. Approximately 66% success in the symptomatic organs. Temporal artery biopsy, kidney biopsy, sural nerve biopsy, testicular biopsy, skin biopsy. So that is also very important here. Where the purpuric spots now. So palpable purpura. That biopsy also will clinch you to know whether there is a fibrinoid necrosis in the vessels is there or not. So these are the important parts where you have to get the biopsy. So vasculitis lesions tend to be focal and the segmental. Angiogram is very much needed, especially for your renal artery stenosis or for your Takayasu arteritis or in the giant cell arteritis, etc. If biopsy is impractical, it is not possible. So, for example, if it is a Takayasu arteritis, so no biopsy for Takayasu arteritis. But what is more important is your angiogram. So, not the angiogram, aortoangiogram. So, total aorta you have to see whether the arch of the aorta, whether the upper limb or subclavian artery, okay, the radial artery, ulnar artery, etc. And also down to the line, so your renal arteries and also your femoral arteries, etc. So important in the large vessel vasculitis like Takayasu arteritis, patients with abdominal pain, renal or the mesenteric vasculitis. This aortogram will definitely help us a lot. See the here. So kidney, the renal. The prognosis untreated is a rapidly progressive, usually a fatal disease. These vasculitis individuals, that is the reason as a postgraduate of the general medicine, so you should know a basic overview of the vasculitis population. So it is up to you to at least to suspect the vasculitis and act accordingly. Otherwise, it's a rapidly progressive and usually fatal disease. And most of these people are the young children, or the young adults, or the middle-aged children. Okay, middle-aged population. So definitely the productivity is also will be a loss because of the improper diagnosis. The prognosis is determined by the extent and the number of the organs involved, obviously. So the more and more internal organs involved, it is a multi-system disease, and definitely they need more and more immunosuppressive drugs. When the more organs are involved, don't be happy with the steroid alone. That is the time you have to add azathioprine, or that is an indication to add your mycophenolate mofetil, or to give a cyclophosphamide as a pulse therapy, at least once in 15 days or once in a month. About 50 milligrams of the cyclophosphamide as a pulse dose therapy. Okay. And then this is the time you have to use the biologicals also with a multi-organ involvement, like rituximab or etanercept or infliximab or adalimumab, etc. Okay. So the morbidity and the mortality can be prevented if recognized and treated early. So don't be happy with only steroids alone. Steroids are the very, very important drugs in treating the vasculitis. And if the vasculitis is beyond the management of your steroid therapy, you should be able to add some more drugs like immunosuppressive drugs, what I have told you just now. And also sometimes you have to add the biologicals also, because it is a progressive disease, it is a dynamic disease, and it is a fatal disease. So the treatment is determined by the type and severity of the organ involvement, rate of the disease progression. It is a slow onset, so you'll be happy with the steroid alone. It is very aggressive, you add some more. Add some more immunosuppressive drugs along with the steroids. Steroids usually 1 mg per kg initially, and you have to give it for about 6 weeks, or maybe 8 weeks, or maybe the 12 weeks. So a long-term management of the steroid therapy will lead to osteoporosis. So these people, they need your vitamin D3 supplementation, calcium supplementation, and biphosphonate supplementation. So the management of the osteoporosis is a very, very important, especially a postmenopausal woman with these vasculitis, when these people are on a long-term basis of your steroid therapy. Pulse dose corticosteroids are also useful in some cases, and immunosuppressive drugs, already I told you, cytoxan is nothing but cyclophosphamide. Methotrexate we can give it. HSP, that is Henoch-Schönlein purpura, a small vessels, post-capillary venules, palpable purpura here, arthralgias, abdominal pain, and renal disease. Males and females are equally involved here. Mean age is 5 years. Preceding urinary upper respiratory tract infections in 2/3, at least 1 to 3 weeks. History of the upper respiratory tract involvement will be there, maybe in the form of the cold, or maybe the nasopharyngeal irritation, or pharyngitis, etc. The tissue deposition of the immunoglobulin A containing immune complexes in the skin, kidney, and the bowel. If you take the biopsy, so they contains IgA vasculitis. Here the GI involvement is about 85%. Severe cramping, abdominal cramps, abdominal pain, nausea, vomiting, maybe upper gastrointestinal bleeding or the lower gastrointestinal bleeding. Major hemorrhage or intussusception is an uncommon but life-threatening complication in the children. Renal involvement 10 to 50%. Mostly the GI involvement here 85% HSP. Then the renal involvement. Renal disease more severe in the adults. It determines the prognosis. So the more severe the renal involvement, obviously they need very aggressive management and sometimes very fatal disease also. Many recover with no therapy, maybe self-limiting in some individuals. Asymptomatic hematuria, proteinuria, and renal insufficiency more the crescentic glomerulonephritis, and 0.5% they progress to end-stage renal disease. What are the uncommon in HSP are testicular involvement, pulmonary hemorrhage, and CNS complications. Usually single episode less than the 4 weeks duration, 40% recurrence rate after the period of the wellness. So in all the vasculitis, recurrence is the rule. Mostly these vasculitis people, they recur. So it is our duty not to have the much more recurrences in our people. So long-term management of the steroid therapy is always needed in the vasculitis people in order to avoid the recurrences. So the recurrences has to be reduced by the proper usage of your steroids for a maximum period, for long periods. So treatment is a supportive measures depending on the involvement, suppose GI involvement or renal involvement, etc. Corticosteroid for GI vasculitis and the hemorrhage. Corticosteroids early in the nephritis. Churg-Strauss vasculitis. It's a necrotizing granulomatous vasculitis of the small arteries and the venules. Okay. Prior asthma. Started on leukotriene inhibitors and weaned off the steroids. So mostly these people, Churg-Strauss vasculitis, they have an history of the bronchial asthma. So allergic rhinitis, eosinophilia, pulmonary infiltrates, or intra or extravascular granulomas. Here the criteria 4 out of the 6. So these are the 6 criteria I am giving you, and 4 out of the 6 are positive. So your diagnosis is Churg-Strauss vasculitis. So history of the asthma or past history of the asthma, the present asthmatics. Eosinophilia more than the 10%. Neuropathies, either the mononeuropathy multiplex or the polyneuropathy. Pulmonary infiltrates, they are the non-fixed. Paranasal sinus abnormality, so get an X-ray of the paranasal sinuses or the CT paranasal sinuses, and extravascular eosinophils. So these are the very important criteria in Churg-Strauss vasculitis. So mostly the asthmatics, eosinophilia, and then the pulmonary infiltrates. So neuropathies. So this is the Churg-Strauss vasculitis. Asthma, eosinophilia, neuropathy, either mononeuropathy multiplex or the polyneuropathy, and pulmonary infiltrates, and paranasal abnormalities, sinus abnormalities, and extravascular eosinophils. Asthma precedes the vasculitis in most of the cases. Confusion with the Wegener's. Nasal or the sinus itchiness is non-destructive. Pulmonary nodules are the less common. So these two are very much peculiar or differentiate points from the Churg-Strauss vasculitis and the Wegener's granulomatosis. In Wegener's granulomatosis, there will be the pulmonary nodules. So Churg-Strauss vasculitis, you have the P-ANCA positivity. C-ANCA where? Wegener's. You can consider as a Wegener's or the Wegener's. Okay. C-ANCA positive there. Here it is the P-ANCA. What is the other vasculitis which is positive for the P-ANCA? Yeah, microscopic polyangiitis. Okay. So the more responsive to the steroids alone, this is Churg-Strauss vasculitis. So we'll move on to the Wegener's granulomatosis. It's a necrotizing granulomatous vasculitis of the small vessels. Affects the persons of the any age group. No significant sex predilection. So more or less male and female is the same. Both the upper and the lower respiratory tract involvement. As I told you, upper respiratory tract involvement in the form of sinusitis or sinus perforations. Okay. In the lower respiratory tract involvement, maybe the pulmonary nodules, etc. And here the glomerulonephritis is also there. Along with your respiratory tract involvement, glomerulonephritis, the renal involvement here. Frequently, as vasculitis of the other organs also may be involved in the Wegener's granulomatosis. Nasal and the sinus disease is destructive. Renal follows the respiratory, may progress very rapidly. And non-specific abnormalities like conjunctivitis, scleritis, episcleritis, proptosis. Here Here the criteria for the Wegener's granulomatosis. 2 or more, what are they? Nasal or oral ulcers, or the purulent or the bloody discharge, abnormal chest X-ray in the form of the nodules, some focal infiltrates, some cavities. Abnormal urine sediment, especially the microhematuria, and RBC CAS. Granulomatous inflammation. If you get the biopsy, so there will be the vasculitis in the form of the granulomas also. So that is the Wegener's granulomatosis. So here the nasal, the upper respiratory tract, and then the nodules and the cavities, and the lower respiratory tract and the lungs, and there will be the renal involvement in the form of the hematuria and the RBC CAS or the proteinuria, and then the biopsy shows you granulomas and inflammations, granulomatous inflammations. Wegener's, here the C ANCA, 90% in patients with the classic symptoms. So classic symptoms means upper respiratory, lower respiratory, and renal. It facilitates the clinical diagnosis. Once you are suspecting the Wegener's granulomatosis, if you get the ANCA positivity, and ANCA is of the C ANCA positivity, so definitely you are dealing a case of the Wegener's granulomatosis. It does not eliminate the need for the biopsy. Still you require the biopsy, not for the intensification of the therapy. Open biopsy, the paranasal sinuses, or the nasal, cavities, larynx, and the lung. Renal biopsy rarely distinctive enough to be definitive. Usually renal biopsy is very cumbersome, and usually you don't advise the renal biopsy in Wegener's granulomatosis, provided if you have these classical features, and if the C ANCA is a positivity, and obviously you are dealing a case of the Wegener's granulomatosis where renal biopsy is not required, straight away you can go for the high doses of the steroids and some immunosuppressive drugs as and when required. Outcomes, interventions. If you don't intervene this patient, survival 50% at 5 months, very high mortality rate. Only 50% live beyond the 5 months without any management. So it's a fatal disease and aggressive disease. If you start the glucocorticoids, so you can prolong the life by 1 year in 50% of the population. And if you use the steroids plus cytoxan, that is your immunosuppressive drugs, then about 80% of the 8 years. So what is the take-home point for the Wegener's granulomatosis? Identify much early, and not only be happy with the steroids alone, add immunosuppressive drugs along with your steroid therapy. So that immunosuppressive drugs may be your cyclophosphamide or azathioprine or mycophenolate mofetil, sometimes maybe the biologicals also. So these are the distinctive features between the Churg-Strauss vasculitis and the Wegener's granulomatosis. Asthma is very common there, uncommon in Wegener's granulomatosis. Eosinophils are very common in Churg-Strauss vasculitis. So here, very occasionally. Atopy, that is your allergy, is more common in the Churg-Strauss vasculitis, whereas uncommon in Wegener's granulomatosis. So the 3 important points in favor of the Churg-Strauss vasculitis is the asthma, eosinophilia, and allergic manifestations. Upper airway destruction is uncommon here, but Wegener's granulomatosis is very common in the form of sinus perforation or sinus destruction or in chronic sinusitis. Pulmonary nodules are very common in Wegener's granulomatosis because it involves both the upper respiratory tract and the lower respiratory tract. And renal failure is very high in the Wegener's granulomatosis. Okay. Now move on to the polyarteritis nodosa. It's a primary systemic necrotizing vasculitis. Here the medium-sized arteries, very rarely the veins, never large elastic arteries. Mostly the large arteries we think of Takayasu or the giant cell arteritis or temporal arteritis. It may be a manifestation of other diseases like rheumatoid arthritis, Sjogren's, Hep B or Hep C. Limited, a progressive and the fulminant. Okay. Any age here, peak age is between 3rd to the 6th decades, and male is to female 2:1. It is more common in the males, polyarteritis nodosa. Constitutional symptoms like fever, malaise, weight loss, arthralgia. Not only the arthralgia, arthritis also there in some of the populations. Skin lesions like purpura, enlarged lesions, elevated lesions, maybe the skin ulcers. Neurological, mostly the peripheral neuropathy rather than the central neuralgias. Renal in about 70% of the cases. Hypertension, 25% of the cases. Cardiac in about 50% of the cases. Gastrointestinal system. And the classic PAN, rare lung disease. That is the take home point. In polyarteritis nodosa, respiratory involvement is very, very, very rare. Both the upper respiratory tract and the lower respiratory tract is there in the vaginous granulomatosis. History of asthma or atopy or eosinophil is there in Churg-Strauss vasculitis. Whereas on polyarteritis nodosa, the lungs are spared here. Okay, so mostly the constitutional symptoms, arthralgia or arthritis, skin lesions, neurological, renal, hypertension, cardiac and gastrointestinal, but a rare lung disease is in classic polyarteritis nodosa. That is the most important thing here. You will have the anemia in most of the vasculitis individuals. You will have the anemia, leukocytosis, thrombocytosis. Okay, ESR elevation, high sensitive CRP is also elevated. Hypocomplement anemia, your C3 and C4 levels at a lower level. Hep B is positive in nearly 30% of the population. In some of the cases, no, even the 50% is also positive. Hep B associated polyarteritis nodosa. Hep C antibodies in about 5% of the cases. And P ANCA less than the 10%. C ANCA is almost rare. So you need not remember the C ANCA and the P ANCA relates, but one thing is very clear that it is associated with the Hep B very commonly to the tune of about 30 to 50% of the cases. Polyarteritis nodosa, how to diagnose it? The biopsy is the rule here. It's the gold standard. Skin biopsy or soral nerve biopsy, muscle biopsy, liver biopsy, testis, temporal artery. Renal does not allow the differentiation of the type of the vasculitis, segmental necrotizing glomerulonephritis. Angio, abdominal, evidence of intra-abdominal involvement, other involved organs not available for biopsy. See the picture here. Untreated, what will happen? 85% mortality at the 5 years. And treatment, 80% survival at the 5 years. Nowadays, no, even the 95% survival at the 5 years because of very good molecules in our hand, like the biologicals also. So steroids, we have to give it in the pan and also have to use the cytotoxic drugs. 40% relapse, medium is the 33 months. That depends on the persons, depends on the age, depends on the country. But one thing is very clear that these vasculitis diseases are very, very commonly relapse. So that is the reason long-term management of the steroid therapy is very much useful here. And then you're using the long-term steroid therapy, you have to see whether these people will not go for the osteoporosis. So osteoporosis management is also must be there in people with a chronic steroid therapy. So this is the 32-year Korean woman, presents with weight loss, low-grade fevers and arthralgia. So constitutional symptoms, weight loss, fever and arthralgia. She notes back pain between her shoulder blades. She notes pain in her arms with any prolonged activity. Recent labs are notable for a platelet count of 8,800 K. That means nearly 8 lakhs. Okay. ESR is 130. So here thrombocytosis and also high ESR. Heart rate is 100. BP 60/40 in both the arms. So hypotension. What is the next step in her management? Hospitalized for further evaluation. Order blood cultures. Get an ANE under rheumatoid factor. Perform a careful exam. Listen for the subclavian bruise. So that could be the reason for your BP 60/40. Okay. Administer the IV saline. Advise the patient to begin iron supplementation. So hospitalized for further evaluation because she is in severe hypotension, 60/40. Heart rate nearly tachycardia. ESR 130. Severe thrombocytosis. And she is symptomatic. Some constitutional symptoms are there. Weight loss is there. And also she had arthralgia or arthralgia between the shoulder beads, that is the interscapular arthralgia, and also in your arms arthralgia. So that is the PAN part. Now move on to the Takayasu arteritis. So the name given by a Japan medical scientist by name Takayasu. It's a large vessel vasculitis, unknown etiology. Aorta and its branches are involved here. It is also called as a pulseless disease. Women in the reproductive years is a very, very common here. 10 times more when compared to the males. Asia, Eastern Europe and Latin America are very common. Granulomatous panarteritis. All the three layers will be involved in Takayasu arteritis. 98% of the stenotic lesions. So that is the reason if it involves the renal artery, these people will present with the accelerated hypertension. Okay, the blood pressure will be 260 by 140. And then if you advise the renal angiogram, so that shows a narrowing of the renal artery. Then they will be subjected for the angioplasty there, and then blood pressure will be subsided, and these people will not require any lifelong antihypertensive medications. So that is the beauty of identifying the secondary cause of your hypertension. So if you address the secondary cause, so you need not use the lifelong medication of the antihypertensive medications. So 98% they have the stenotic lesions and 27% have the aneurysms. So this is because of the weakening of the vessel wall. So in the large vessels, it's the pan arteritis. So all the three layers will be inflamed, and then the wall will be weak, and there will be the formation of the aneurysms also will be there. Subclavian and aortic arch is the most common, 93%, and 40 to 80% renal artery stenosis is also common, presented with accelerated hypertension or malignant hypertension. Arterial stenosis or organ ischemia, it will be present with a claudication, TIA or stroke, young strokes, renal artery hypertension, heart failure, acute left ventricular failure because of the accelerated hypertension, angina, myocardial infarction, or mesenteric vascular insufficiency. So they are very common in the Takayasu arteritis. In the absence of the complications like retinopathy or hypertension or aortic vein insufficiency, 15-year survival is 95%. In the absence of the complications, most respond to the steroids alone, and 40% will need the cytotoxic drugs. See whether they need a cytotoxic drugs or not. So definitely the picture will tell you. So when the fellow is having only Takayasu arteritis, no other complications, so definitely the steroids will help them. Suppose if the patient is also having the multi-organ involvement, so definitely they need a cytotoxic agents along with your steroid therapy. See the beautiful picture here, the temporal artery. Okay, so very dilated, elongated. So their ESR will be very high, presents with our severe throbbing, headache, and maybe the jaw claudication, maybe the tongue claudication. Sometimes there may be the sudden loss of the vision also, maybe because of the blocking of the endophthalmic artery. Okay, so these are all the temporal arteritis or giant cell arteritis, also called as the cranial arteritis. Large vessel, granulomatous arteritis, extracranial vessels or intracranial vessels. So it's more in the extracranial vessels. Aortic arch vessels are very rare, unknown etiology. Persons over the age of 50, mostly it is more than the 60 or 65, 70. 2 to 3 times more common in the women. Takayasu arteritis is also same, more common in the women. Giant cell arteritis is also more common in the women. Segmental vessel inflammation, multinucleate giant cells, lymphocytic predominance. Thrombosis is very common here. Giant cells are not required for the diagnosis. It's a non-specific constitutional symptoms are there. Headache more. Scalp tenderness is there. Nodules. Temporal artery tenderness. Some visual symptoms I told you, blindness. Intermittent claudication, maybe the jaw, tongue, extremities. Neuropathies and TIA and the strokes. Respiratory tract involvement in 10% of the patients. And polymyalgia rheumatica. So this is also very common in the giant cell arteritis. So females more than the 60 years of the age group, and the diffuse pains, arthralgias, So the polymyalgia rheumatica is also commonly associated with the giant cell arteritis. Again, the treatment is mostly steroids alone. ESR is elevated here, CRP is elevated, mostly the anemia, thrombocytosis, increased alkaline phosphatase. Biopsy is there, vascular involvement, length, if normal, temporal artery examination, obtain 3 to 5 centimeter sample. I told you earlier 2 centimeters. So even the 2 centimeters are not sufficient. Maybe 3 to 5 centimeter sample and examine at the multiple levels, because skip lesions, to avoid the skip lesions, you have to have a large segment biopsy. Prednisolone, the dose is 1 milligram per kg body weight per day. Taper after the symptoms or the lab resolved. This is the very important. Even though the symptoms are resolved, still the ESR and the high sensitivity CRP are very high. Again, you have to continue the high dose steroid therapy only. Once there is a symptomatic relief and also your ESR and the CRP is coming down, then only you have to taper the doses of the prednisolone. Slow taper at 15 milligrams per day. That depends on you. So some taper 10 milligrams per day, some 15 milligrams, some 20 milligrams, etc. And lab and symptoms definitely will tell you how much reduction must be there. And long-term steroids are also needed for most of these individuals. Again, avoid the osteoporosis. Steroid sparing with the methotrexate, so that can be used in some individuals. 30% relapse with the steroid tapering dose, especially prednisolone less than the 20 milligrams per day. Vertebral compression fractures. Other serious steroid toxicities like hypertension, diabetes, heart failure, cataracts, because we are using the large doses of the steroids. So obviously we are introducing the Cushing-White phases. So obviously they get diabetes, steroid-associated diabetes, steroid-induced hypertension, steroid-induced heart failures. So these are all very common. So one, as a good physician, you are definitely identify these at an early time, and you have to address the hypertension, you have to address the diabetes, etc. Because you should not reduce the dose of the steroids on one hand. Once you reduce the steroid doses, again the disease is recurrence. So to avoid the recurrence, we have to use the long doses of the steroids. Along with the steroids, you see that whether the fellow's blood pressure is going up there. So again, you have to use the antihypertensive medications to reduce the hypertension. You have to use these gliptins, or you have to use the metformin, or you have to use the basal insulins to reduce the diabetes burden. In the same way, the heart failures, etc. These are the differential features between the giant cell arteritis and the Takayasu arteritis. Giant cell arteritis, female and the male, 2:1, whereas the Takayasu 8:1. So more in the Takayasu is more in the females, 8:1. Age group, giant cell arteritis, elderly. Takayasu arteritis, middle age. The average age of onset, giant cell arteritis is 72 years, whereas the Takayasu is just 25 years. Visual loss is very common in the giant cell arteritis, very rare in Takayasu arteritis, because giant cell arteritis that involves extracranial vessels. Involvement of the aorta or its merged branches is 100% Takayasu arteritis, sometimes giant cell arteritis also. Pathology, both are granulomatous arteritis. Pulmonary artery involvement is a possible in Takayasu, no in giant cell arteritis. Renovascular hypertension is a very common in Takayasu arteritis. Claudication is a very common in Takayasu. Ethnic groups with the highest incidence, Asians and Takayasu arteritis. Giant cell arteritis not in Asians but Scandinavians. Steroid response, very good in giant cell arteritis, good in Takayasu arteritis. Presence of the bruise, more in Takayasu arteritis, very less in giant cell arteritis. That is the difference between the giant cell arteritis and Takayasu arteritis. So common vasculitis presentations, water in the genital ulcers, think of the Behçet's, upper and lower airway diseases and glomerulonephritis, your Veckenus, so Sianca, septal perforation, epistaxis, recurrent sinus infections, pulmonary nodules, hemoptysis, so these are all in Veckenus. Young female with arm and leg fatigue and hypertension, accelerated hypertension, young female. So think of Takayasu arteritis. Palpable purpura, maybe the small vessel vasculitis. Hep B, polyarteritis nodosa is commonly associated. About 30 to 50% of the polyarteritis nodosa are associated with hepatitis B and sometimes hepatitis C also. Hepatitis C is more common in the cryoglobulinemia. So these are the causes of the secondary vasculitis. Okay. So some infections, especially in India, tuberculosis. So tuberculous vasculitis, Hep B and Hep C, syphilis, infective endocarditis. So these are the infections. Connective tissue disorders like lupus, RA, systemic sclerosis, you have the vasculitis picture. Coagulopathies like purpura, thrombotic thrombocytopenic purpura, you will have the vasculitis picture. Neoplasms, especially the lymphomas, leukemias, you will have a vasculitis picture. Drugs, penicillin, sulfonamides, allopurinol, and thiazide diuretics. They cause vasculitis like picture. And sarcoidosis and cryoglobulinias. So these are all the secondary vasculitis causes of the secondary vasculitis. Okay. So this is depending on the vessel. So large vessel, then the medium vessel, then the small vessel. Okay. Large vessel, GT, that is our giant cell arteries and Takayasu. And medium vessel is a PK, not Prashant Kishore, but here polyarteritis nodosa and Kawasaki, PK. Okay. Small vessel. Then common clinical manifestations of the vasculitis. Okay. Large vessel vasculitis, you have the claudication pain of both limbs and absent pulses, asymmetrical blood pressure in the limbs, and aortic dilatation of the aneurysms and the bruits. So they are on the large vessel vasculitis picture. In the medium vessel, you have the cutaneous nodules, skin ulcers, livedo reticularis, distal gangrenes, mononeuritis multiplex, and microaneurysms. So they are the features in the medium vessel vasculitis. In small vessel vasculitis, the palpable purpura, glomerulonephritis, alveolar hemorrhage, urticaria, vesicobullous lesions, splinter hemorrhages, cutaneous extravascular necrotizing granuloma, uveitis, scleritis, episcleritis, etc. So the small vessel vasculitis, you have some ophthalmological features, sometimes respiratory feature, sometimes some nephrological features. They are all in small vessel vasculitis. So these are the large vessel vasculitis in our Indian population. Takayasu is very common, I told you. Giant cell arteritis in elderly individuals, not that common. Tuberculous arteritis is a very common in our Indian population. Syphilitic aortitis, nowadays we are not seeing much. Rheumatoid aortitis. So because of the rheumatoid arthritis, vasculitis. Again, rheumatoid arthritis is a very common disease in our Indian population. Ankylosing spondylitis is a very common in young individuals, especially the males with your bamboo spine, and isolated aortitis. ACR, American College of Rheumatology classifications, criteria for Takayasu arteritis. Onset before the age of the 40, decreased brachial artery pulse, limb claudication, unequal arm blood pressures, more than the 10 millimeters mercury difference between the right arm and the left arm, subclavian or the aortic bruit, angiographic evidence of narrowing or occlusion of aorta or its the branches. So aortogram is very, very important Takayasu arteritis. Presence of the 3 or more criteria out of these 6 criteria is 91% sensitive and 98% specific for the diagnosis of Takayasu arteritis. So these 6 are very, very important points. A is decreased brachial artery pulse, limb claudication, unequal blood pressures, bruit, and angiographic features. So this is the Doppler picture showing the narrowing of the proximal abdominal aorta. See the aneurysmal formations here. Again, here, metabolically active lesions. So the points to remember, or in Takayasu arteritis, the recurrence rate is very high with angioplasty and the surgical procedures. Bypass graft gives better results than the angioplasty. So once you think of the Takayasu, so of course the immediate purpose we plan for the angioplasty, but definitely the graft surgery is always better. But nowadays we also have very good quality angiogram. Angioplasty is also available right now. So that could be also as good as your bypass grafts. Surgical intervention should be deferred until the disease is in the remission. Angioplasty gives good short-term results, though the long-term results are disappointing. See the palpable thickened non-pulsatile temporal arteries. Claw hand due to the mononeuritis multiplex. Foot drop, again the mononeuritis multiplex in the palm. Polyarteritis nodosa. So this is the ACR classification criteria for PAN. Here 3 out of the 10 criteria. So what is the PAN? Weight loss, livedo reticularis, testicular pain at the tenderness, myalgia, leg weakness or tenderness, mononeuropathy or polyneuropathy, diastolic BP more than the 90, increased blood urea nitrogen and the creatinine, presence of FB, angiography showing aneurysms or occlusion of the arteries, biopsy, granulomatous and mononuclear cell infiltration. So one biopsy point, one angiogram point, one hepatitis B positivity, and then others are the clinical points here. Weight loss, livedo reticularis, some testicular pain at the tenderness, myalgia, mononeuropathy, multiplex or polyneuropathy, diastolic BP more than the 90, and then the elevated urea creatinine levels. So these are the criteria for your PAN. See the sinus infection with a nasal crusting. See the with polyangiitis. So scleritis and granulomatosis, polyangiitis. The saddle nose deformities. CT, sinusitis, the fluid collection. See the nodules here, lower lobes. See the cavitating lung nodules. Non-caseating granulomas with necrotizing vasculitis. See the vascular pictures, multiple cutaneous vasculitic lesions. This is the positive P ANCA. Eosinophils rich granulomas. Vasculitis associated with the granuloma formations. So these are the vasculitis associated with the granuloma formations. So the large vessel vasculitis like giant cell and Takayasu, Cogan syndrome, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, primary CNS angiitis and rheumatoid vasculitis, you will have a granuloma formations. So this is IgA vasculitis. A purpura is the main important thing, a palpable purpura. And plus one of the following like abdominal pain, arthralgia, some histopathology, some renal involvement. The raised palpable vasculitic picture, IgA vasculitis here. So there are pictures of the HSP, skin involvement, 100%, palpable purpura, petechia, ecchymosis, urticarial regions, cutaneous edema. Joint involvement of 80%, maybe arthralgia or arthritis, gastrointestinal, abdominal pain, etc. Renal diseases, neurological, pulmonary. So they are all features of your HSP. What is the treatment? Arthralgias or arthritis. You can use the NASIAs, short-term basis only. Persistent skin rashes, you can go for the steroids. Gastrointestinal disease, again the steroids. Nephrotic syndrome, steroids, ACE inhibitors, and immunosuppressive drugs like azathioprine, maybe 1 to 2 milligrams per kg body weight. Rapidly progressive glomerulonephritis, you have to go for the pulse steroids. That means your methylprednisolone. Maybe you can be used 500 milligrams to 1 gram per day for about 3 to 5 days. That is the methylprednisolone. First you give it when there is a rapidly progressive glomeruloscleritis. Okay. So give for the methylprednisolone maybe 1 gram for 3 to 5 days. And then the large doses of your steroids. And then you add immunosuppressive drugs like azathioprine maybe 50 milligrams. Mycophenolate mofetil maybe 2 to 3 grams a day. and plasma exchange also useful in some cases. So this is the besides you will have a painful ulcers, captus ulcers. See the large palatal ulcer, the Behçet's disease. See the multiple vesicular eruptions. So this is the scrotal ulcer, scleritis, hypopia and uveitis, large pulsatile swelling due to the aneurysm of the femoral artery. See the aneurysm here, surgical scar of the aneurysectomy by the vascular surgeons, angiograms after aneurysectomy, cutaneous vasculitis, the typical vasculitis pictures. So now the 10 more questions to you. P. Anca is associated with. What is your answer? Polyarteritis nodosa, microscopic polyangiitis, vaginous, Henoch-Schönlein purpura. So right answer is the B. B for Bombay, microscopic polyangiitis. Okay. In vaginous, C. Anca. C. Anca. Giant cell arteritis. All are true except high doses of steroids is the drug of choice. ES are usually elevated. Intracranial ICA is particularly susceptible. Mainly affects people more than 60 years of the age group. C. It is the extracranial internal carotid artery, not the intracranial. It is the extracranial, the temporal artery. Okay. So giant cell artery, the drug of choice is steroids. ESR is very much elevated. Age more than the 60 years. Pulse absent in the radial arteries is seen in. So it's a Takayasu arteritis. Not in aortic regurgitation. It's a bounding pulse. Okay. Classic PAN. All are positive except multisystem necrotizing vasculitis. Yes or no? Yes. Medium vessels involved? Yes. Pulmonary involvement is a characteristic feature. 30% patients positive for Hep B. C. Calcutta is the right answer. Here the pulmonary involvement is rare. Okay. It's not a characteristic feature in PAN. Polyarteritis nodosa. It's a multi-system disease. Medium vessel involvement. 30% of the Hep B. But the pulmonary involvement is almost a rare. Kawasaki disease has the following features except coronary artery aneurysm, conjunctival suffusion, thrombocytopenia, desquamation of the skin of the fingers and the toes. So thrombocytopenia, they allow thrombocytosis. So this Kawasaki disease is mostly aneurysm formation, coronary arteries. So premature coronary artery disease in the children, conjunctival suffusion is very common, and the skin lesions in the fingers and the toes are also very common. Thrombocytosis rather than the thrombocytopenia. Here 25-year-old female develops the serious arteritis media of the left ear with cough, hemoptysis, hematuria and epistaxis for 1.5 months. Hemoglobin 7 grams, blood pressure 170/100, proteinuria positive, rheumatoid factor is positive, ANCA positive. What is your diagnosis? So vaginous granulomatosis, or rheumatoid arthritis, or rapidly progressive glomerulonephritis, or Goodpasture syndrome. What is the diagnosis here? So mostly the vaginous granulomatosis. Here it has a more upper lobe involvement, upper respiratory tract, lower respiratory tract involvement. Okay. And then there will be the renal involvement, proteinuria, and rheumatoid factor positivity may be a false positive here. Okay. And then the ANCA positivity. See ANCA positivity. Regarding HSP, all are true except associated with the glomerulonephritis, a palpable purpura, ANCA negativity, and thrombocytopenia. Yes. Again here thrombocytosis. In all the vasculitis features, we will have a thrombocytosis. Anka negative only HSP, not P positive or the C positive. All other three diseases, only three diseases are ANCA positivity. Okay, Wegener's the C, and then your microscopic polyangiitis is the P positive. Okay. Here the right answer is thrombocytopenia. Hep B is a major risk factor to Wegener's granulomatosis, Kawasaki, Behçet's or Polyarteritis nodosa. Yes, D is the right answer. Delhi. So polyarteritis nodosa, about 30 to 50%. Hep B is a commonly associated here. Common features in the many vasculitis disorders are all common for all the vascular diseases, most of the cause, except a rash, a palpable purpura. Yes or no? Yes. Constitutional features, fever, fatigue, arthralgia, weight loss. Yes or no? Yes. Biopsy gold standard. Yes or no? Yes. Poor response to steroids. No. They have very good response to steroids. So the constitutional features are there. Palpable purpura are there. Biopsy is the gold standard. And then if your response to steroids is a very, very good, very responsive in most of the vasculitis population. Last question. Drug therapy of the Takayasu arteritis includes all except prednisolone 1 mg. Yes, we use high dose of the prednisolone. Azathioprine 2 milligrams. Yes, we use azathioprine. Mycophenolate mofetil. Yes, as an immunosuppressive drug. Doxycycline 100 to 200 milligrams antibiotic. Any role of antibiotics in vasculitis? No. No. So here the right answer is D, Delhi, not the doxycycline. So prednisolone is useful, azathioprine is useful, mycophenolate is useful. Okay, maybe cyclophosphamide is useful, methotrexate is useful. Even your other biologicals are also useful, not the antibiotics. So thank you very much for your patient hearing.